Hello class, here is the next segment for your autonomic nervous system lecture. As we've already discussed in class, I want you to be able to answer these questions for both the parasympathetic division and also the sympathetic division. Basically, when are they on? We've already discussed they're on all the time, but we should modify that question to when is a particular division in more control of your body. Be mindful of the anatomical locations for the pre- and post-ganglionic neuronal cell bodies for both divisions, what neurotransmitters they release, what receptors are found on the post-ganglionic neuron, what receptors are found on the effector cells. So now I'm going to finish this segment with some discussion on drugs that can affect the release of acetylcholine or block it, or drugs that can bind to various cholinergic receptors and either act as agonists or antagonists. So let's begin that discussion with drugs that are direct acting on muscarinic agonists. Now, again, the game we've been playing in class has been if we target the receptors used by the parasympathetic division and they act as agonists, then that means we're giving more control to the parasympathetic side. Remember the balance analogy that we've been using. So muscarine is a toxin, and it comes from the muscarine mushroom, and I already talked about that. Pilocarpine is a drug that acts in a similar fashion to muscarine. Now I'll remind you, I've been telling you that pharmaceutical companies take toxins found in nature and modify them through changing chemical groups so that they can act like those toxins but without having the toxic effects. So pilocarpine is a drug that is very similar to muscarine. Both muscarine and pilocarpine directly bind to muscarinic acetylcholine receptors. They act as agonists. That means the balance tips in favor of the parasympathetic division. What would we expect in a patient? Slower heart rate, increased gut motility. Again, think parasympathetic. But my question on the screen is, why would we also see profuse sweating in our patient? I'll remind you that the true sweat glands, there are different types of sweat glands here in our dermis. True sweat glands, or the eccrine sweat glands, are controlled, or hardwired I should say, by the parasympathetic division. So these true sweat glands have muscarinic acetylcholine receptors. But as we discussed in class during embryonic development, they come under the control of the sympathetic nervous system. So a patient who eats this muscarine toxin is going to ooze from every pore and orifice. Remember me telling you that from lecture. Now, direct acting nicotinic agonists, well, nicotine is the example. So the nicotinic agonists are going to target nicotinic acetylcholine receptors. I'll remind you, those receptors are found on the postganglionic cell bodies for both divisions of the autonomic nervous system, and they are the most robustly expressed receptors on skeletal muscle. But I'll remind you, they are not the only receptor, acetylcholine receptor, on skeletal muscle. There are also the muscarinic variety. I should say there is also the muscarinic variety. Now we've also already learned in our previous lecture, the dendrites to synapse lecture, about indirect acting cholinergic drugs. These are the drugs that inhibit the acetylcholinesterase. Now I'll remind you, if you inhibit the very enzyme whose job it is to degrade acetylcholine, then that means acetylcholine is going to last longer in the synaptic cleft. And we've already learned about the stigmines, neostigmine, pyridostigmine, physostigmine, and I've already told you about edrophonium and how it is also an acetylcholinesterase inhibitor, but it has a very short half-life. And we've already discussed how we can use edrophonium to determine if a patient is in a cholinergic crisis, which means they've overdosed on their acetylcholinesterase inhibitor, versus a myasthenic crisis, and the fact that that person would need their acetylcholinesterase inhibitor. So all these drugs potentiate the effect of acetylcholine. That means allows it to last longer in the synaptic cleft or neuromuscular junction. Please know, go back to your notes, please understand how we use edrophonium to discern between cholinergic versus a myasthenic crisis. Now, atropine is an antagonistic drug. It is going to specifically block muscarinic acetylcholine receptors. If we are blocking muscarinic acetylcholine receptors, and that means we are blocking parasympathetic pathways, and we should expect to see sympathetic gaining more control in our patient. Again, go back to our balance analogy. So atropine blocks muscarinic acetylcholine receptors, and if we think about blocking parasympathetic, then sympathetic effects should be seen in the patient. Increased heart rate, decreased gut motility, increased bronchodilation, and also pupillary dilation. Make sure you understand that balance analogy. Very, very important for your upcoming exam. Now let's talk about receptors highly used by the sympathetic division. In the previous slide, we were focusing on cholinergic receptors, and the parasympathetic division uses muscarinic acetylcholine receptors, so we just reviewed those drugs. Now let's focus on sympathetic receptors. Now, I want you to know the following sympathetic receptors. Alpha 1, you don't need to worry about alpha 1, alpha, alpha 1 beta, or alpha 1A or B. Alpha 1. Alpha 2, just want you to know them as alpha 2. The betas, I do want you to know beta 1, beta 2, beta 3. Everything in red on this slide I want you to know. So for testing purposes, alpha 1 receptors are highly expressed and used on the involuntary effectors, on the radial fibers, smooth muscle fibers in the iris. We talked about that in class. On the intestines, gut, I just want you to think of it as gut, and on arteries. When alpha 1 receptors bind noradrenaline or adrenaline, we would expect to see pupillary dilation, we would see decreased gut motility, we would see vasoconstriction, and the vasoconstriction would lead to an elevated blood pressure. Alpha 2 receptors, when they bind the adrenergic signal, they actually inhibit further release of neurotransmitter. They inhibit the release of norepinephrine. So these are found on the terminal bouton of the neuron that's targeting the effector. So they are on the postganglionic neuron, but because they are upstream of the involuntary effector, we say they are the presynaptic neuron. So make sure you get those terms right, because when you get to pharmacology, it's going to be pretty confusing. So the presynaptic control, they are on the postganglionic terminal bouton, these receptors. When the postganglionic terminal bouton releases norepinephrine, it diffuses backwards and will bind to these alpha 2 receptors on the terminal bouton. I will draw this for you in class and review it when I next see you. And they are going to prevent further release of the adrenergic neurotransmitter. So it's sort of like a negative feedback. It's not sort of like, it is negative feedback inhibition at its best. Now beta 1 in class, I told you how many hearts do you have. You all said I have one heart. I said, well, this is the adrenergic receptor most widely expressed on the heart. It is not the only, but it is the most highly expressed. When this adrenergic receptor binds the sympathetic neurotransmitters or hormone, It leads to an increased inotropy. That means increased heart rate. Sorry, increased inotropy means increased force of contraction. And it will also lead to increased chronotropy. That means increased heart rate. Don't worry about renin until Unit 4. Beta 2, most highly expressed adrenergic receptor in the respiratory system. I want you to think of that as the primary target for beta 2 receptors, and this will lead to increased bronchodilation. I also want you to know beta 2 receptors are found on blood vessels. This is very important because beta 2 receptors, when they bind to adrenaline, they are going to cause vasodilation. And I'm going to talk to you about the war between alpha 1 receptors and beta 2 receptors. Okay, next, beta 3 receptors, most highly expressed receptor on adipose tissue. And this is going to lead to lipolysis, or use of fats for energy, fuel source. I'll remind you that epinephrine and norepinephrine and dopamine are all catecholamines, and they are all synthesized from tyrosine. Tyrosine is metabolized into L-dopa, a precursor that can cross the blood-brain barrier. And then L-dopa is converted into dopamine. You do not need to worry about the enzymes that I have listed here that cause these chemical reactions. Dopamine can be further processed into norepinephrine, and then norepinephrine is further converted into epinephrine. And epinephrine and norepinephrine differ from each other with a methyl group. I'll remind you that norepinephrine is mostly used as a neurotransmitter in the body, and epinephrine is mostly used as a hormone in the body. Although that is not 100% true for testing purposes, that's how I want you to refer to them. Norepinephrine mostly as neurotransmitter, epinephrine as hormone. Now let's talk about your receptors again. Alpha 1 receptors. What do I want you to know? Alpha 1 receptors, when stimulated, are going to cause pupillary dilation, blood vessel constriction, so it causes vasoconstriction, and I want you to know that it would shut down the GI tract, decrease gut motility. That's what I want you to know for your upcoming Lecture 2 exam. Alpha 2 receptors. These are negative feedback inhibition at its best. They are found on the presynaptic membrane. That means the neuron that is releasing norepinephrine, and sometimes again epinephrine can be used as a neurotransmitter. That neuron releasing those adrenergic neurotransmitters has alpha 2 receptors on the terminal bouton. The norepinephrine, epinephrine can diffuse backwards and bind to those alpha 2 receptors. And when they are stimulated, they will cause inhibition of any further release of those adrenergic signals. There are drugs, clonidine, that can bind to these alpha 2 receptors, inhibit any release of norepinephrine, epinephrine, and then this can be used for hypertension. I'm going to show you why. When neurotransmitters like norepinephrine are released and they bind to alpha 1 receptors on the involuntary effectors, like blood vessels, it causes vasoconstriction, and this leads to hypertension. Well, if you give a drug like clonidine that binds to alpha 2, then it's going to inhibit release of norepinephrine, and that means the alpha 1 receptors won't bind to that drug or neurotransmitter or hormone like epinephrine, and therefore the smooth muscle will relax, and this leads to vasodilation, which will help with the hypertension. Again, we're going to draw this on the board when I next see you in class. You need to make sure you have this down. This is clinically important. Beta receptors. Beta 1, most widely expressed on the heart, will lead to increased chronotropy, that means heart rate, and inotropy, that means force of contraction. This means the heart becomes more efficient as a pump and will lead to a greater ejection fraction. I will explain that more in lecture unit 3. For now, for lecture unit 2, I just want you to know beta 1 will lead to increased chronotropy and inotropy. Beta 2 receptors, when they bind to epinephrine, they are going to cause muscle relaxation. This means bronchial dilation in the lungs, but it will also mean vasodilation on blood vessels, particularly those to skeletal muscle. And we played the game in class, remember? I said if you are running for your life, would you want the blood vessels serving your skeletal muscle to be constricted? You all said no. I said, what about blood vessels serving the brain? You said most certainly not. We would want vasodilation so that we get adequate blood flow to those areas of the body. Beta 3 receptors cause lipolysis, again, fats being mobilized to be used as fuel source. Now, here's another quirky thing. I told you I would explain the war between alpha 1 receptors and beta 2 receptors. And these receptors bind epinephrine, and they are both expressed on smooth muscle found in blood vessels. So they're both there. And what you are seeing graphically on this picture is that there are more alpha 1 receptors on blood vessels than beta 2. However, beta 2 receptors bind epinephrine with greater affinity. So that means if there's a few molecules of epinephrine around, the beta 2 receptors will bind to them at a higher level, a greater affinity. And you're seeing them populate with epinephrine in the bottom left picture here more readily. So that means when there's some epinephrine around, like low levels, we're going to get relaxation of smooth muscle and vasodilation. But in some blood vessels, not all, there are higher levels of alpha 1 receptors. And therefore, when epinephrine levels are very, very, very high, there's going to be more alpha 1 receptors populated, and they will win. They will cause the vasoconstriction. So I understand this is quirky, and you might be thinking, well, Kara, how do you want us to resolve this for testing purposes? I will make that, I will make that very clear in class when I next see you. But I need you to know that both receptors can be found on blood vessels. Different blood vessels can have different degrees of expression for these receptors, but I want you to know, I can tell you right now, for testing purposes, if I ask you a question about blood vessels that have both beta 2 and alpha 1 receptors, I want you to know this quantitative fight over epinephrine. When it comes to low quantities of epinephrine, beta 2 receptors will bind to it more. They have a greater affinity. This leads to relaxation, vasodilation. When there's a lot of epinephrine, huge fight or flight, more alpha 1 receptors, we get the vasoconstriction. Now, speaking of quirky, turns out dopamine is also extremely quirky. There are so many known dopamine receptors, 5 to date, and their nomenclature are DA1, DA2, DA3, DA4, DA5. Okay, turns out DA1 and DA2 are the variety that mediate responses for sympathetic nervous system. So those are the ones we're going to focus on for Unit 2. However, I want you to know that in the brain, of course, we have all of these receptors, and you know what? Dopamine has so many quirky effects. Dopamine has many different effects in the brain. Different regions of the brain express these different receptors, DA1 through 5, and some of these regions can even express different portions of each of these different receptors, which really makes things messy. And the very same receptor can respond to dopamine in very different ways depending on the amount of dopamine. So dopamine is all over the board. How am I going to test you? Well, now listen up. This is what I want you to know for dopamine. I want you to know that dopamine used in the substantia nigra of the midbrain is inhibitory. I've already told you this in a previous lecture. That is true. I told you about Parkinson's disease, which is loss of these dopaminergic neurons in the substantia nigra. These neurons are responsible for releasing dopamine to have inhibitory effects. That means blocking unwanted muscle movement, and I explained the dyskinesia that we see in Parkinson's patients. So if you lose this inhibitory neurotransmitter, you lose the ability to block unwanted movement, and the patient presents with arresting tremors. The unwanted movement presents. Now, how can we help these patients? I told you dopamine cannot pass through the blood-brain barrier, but L-DOPA, the precursor to dopamine, can. The problem is L-DOPA in the bloodstream, as shown here in this picture, can be destroyed by enzymes found in the bloodstream. Don't worry about the names of those enzymes. But pharmaceuticals will combine L-DOPA to another drug, carbidopa, and that I want you to know. And the carbidopa helps block those degrading enzymes. So the L-DOPA lasts longer in the bloodstream and is more likely to cross the blood-brain barrier to enter the substantia nigra cells and be converted to dopamine. But look, enzymes in the blood are not the only threat. There are enzymes in the synaptic cleft, there are enzymes in the brain, other enzymes, that can also degrade L-DOPA and dopamine. So these drugs are these enzymes are COMET, and I explained what that was in a previous lecture, and they are also monoamine oxidase, and we talked about monoamine oxidase inhibitors. So I do not want you to worry about tolcapone, which are the COMET inhibitors. You'll learn about those in Pharm. I want you to focus on the MAOIs. I just want you to know them as MAOIs. I don't want you to worry about the actual drug. So we need carbidopa bound to L-DOPA to preserve it in the bloodstream. And then the patient needs to be on other drugs that will inhibit other enzymes that degrade L-DOPA and dopamine. So the MAOIs, I want you to know that. If the patient is on all these drugs, then the remaining dopaminergic neurons in the substantia nigra have better ability to use the L-DOPA, convert it to dopamine, release it into the synaptic cleft. The dopamine lasts longer in the synaptic cleft because it's not taken back up again or degraded, and therefore can bind to downstream receptors on downstream neurons that will have the inhibitory effect required to stop the unwanted movement. Again, what drugs do I want you to know? I already told you in class that Parkinson's disease is a problem with a balance between dopamine and acetylcholine. Acetylcholine, of course, is excitatory on skeletal muscle. And we talked about balance between IPSPs, inhibitory postsynaptic potentials, and EPSPs, excitatory postsynaptic potentials. And muscle movement is a balance between shutting down the neuron that targets skeletal muscle versus allowing it to target skeletal muscle. I already impressed upon you there is no such thing as an inhibitory neurotransmitter released onto skeletal muscle. Therefore, if you don't want skeletal muscle contraction, you need to shut down the somatic motor neuron. That somatic motor neuron needs to have more IPSPs, right? We talked about this so much in class. So it's a balance between this inhibitory neurotransmitter, dopamine, and the excitatory neurotransmitter released on skeletal muscle.
Substantia nigra failure, or destruction of it, means loss of dopaminergic neurons, loss of the inhibitory signal being generated in the brain. And then the patient presents with unwanted movement. What can we give them? We give them L-DOPA. It can cross the blood-brain barrier, but it needs to be combined with carbidopa. So the carbidopa allows the L-DOPA to last longer in the bloodstream. L-DOPA can cross the blood-brain barrier. I already told you in general there are other drugs patients will have to be on to block the enzymes that can destroy L-DOPA and dopamine, and I don't want you to worry about their names. I just want you to just know them in general as MAOIs, monoamine oxidase inhibitors, and there are others you will learn about in Pharm. Now, this chart is a very good chart. You should start to know it's clinically relevant. I want you to know the actual receptors bound by these neurotransmitters and drugs. Dopamine only binds to alpha-1 and beta-1 and dopamine receptors, and you should know I have taken this chart from the pharmacology textbook used at Saddleback. So you're going to see this again if you take Pharm with us again. So I need you to know this. Norepinephrine binds to alpha-1, alpha-2, and beta-1. Epinephrine across the board, alpha-1, alpha-2, beta-1, beta-2. Isoproterenol, I'm going to explain what this is. It is a beta-1, beta-2 agonist. It's going to stimulate those. Ephedrine, and drugs like ephedrine, binds to all the alphas and betas. In fact, ephedrine and methamphetamines, they also lead, I'm going to tell you how they work, but they lead to more dopamine release, and therefore the dopamine receptors, of course, would be stimulated. Phenylephrine is the new formula of pseudoephedrine. You learn a drug that I'm going to tell you about in a little bit. Clonidine, I've already explained to you. It is an alpha-2 agonist, and this would lead to inhibition of any further release of norepinephrine and epinephrine. Albuterol is a drug that is a beta-2 agonist, and this is used for treating asthma. Okay, so drugs that behave like norepinephrine/epinephrine, they're sympathomimetic. I gave you the chart previously. Isoproterenol stimulates both beta-1 and beta-2 receptors. If a patient is on this, it will help with their asthma. It'll give them more bronchial dilation by stimulating beta-2, but it's contraindicated if they have hypertension, because you'll notice it'll stimulate the beta-1 receptors on the heart as well. Dopamine can be used in a clinical setting to treat hypotension. If a patient has low blood pressure, it stimulates both alpha-1 and beta-1 receptors. Beta-1 leads to more chronotropy and inotropy. Alpha-1 stimulated will lead to vasoconstriction. Albuterol, like I explained on the previous slide, will bind to beta-2 receptors, and this leads to bronchial dilation that helps with asthma. Phenylephrine is the new formula for Sudafed. Sudafed used to be pseudoephedrine. The pseudoephedrine, of course, was used by people to make methamphetamines and amphetamines, and now you need to basically sign over your firstborn child if you want that old formula of Sudafed. The phenylephrine binds to alpha-1 receptors. Why does this help act as a nasal decongestant? Well, the blood vessels that go to your nose, they are swollen. That's why you have the congestion. So if you take this phenylephrine, it binds to alpha-1 receptors and causes vasoconstriction. And therefore, you aren't as congested because your blood vessels aren't swollen, aren't vasodilated. Now, the old formula, like I said, the pseudoephedrine, was used because it's no longer readily available. You have to go to the pharmacist, It was used by people who are making drugs, methamphetamines. Now, how do those work? How do ma huang works? Ephedrine, amphetamine, methamphetamine. Okay, these drugs allow more release or synthesis of norepinephrine, but not just norepinephrine, dopamine and serotonin. And we learned about serotonin being your feel-good or mood elevator. So that's why meth addicts want that pseudoephedrine to convert it to methamphetamine. Now, what do I want you to know for testing purposes? I want you to know that pseudoephedrine and these drugs cause more norepinephrine release. But if you go back to the previous slide, you'll notice that I'm going to click backwards. You'll notice that ephedrine here binds to alpha 1, alpha 2, beta 1, and beta 2. That these drugs not only lead to more norepinephrine synthesis, and you would predict just alpha 1, alpha 2, beta 1 receptor stimulus, but because so much norepinephrine is being released, I'll remind you a great quantity of norepinephrine also gets converted to epinephrine. So that's why I want you to know ephedrine and pseudoephedrine and methamphetamines, they can cross-react with all these receptors. Okay, so alpha 1, alpha 2, beta 1, beta 2. Now our last slide, these are drugs that are going to block the effect of norepinephrine. These are antagonists. So phentolamine is an alpha blocker. If someone takes phentolamine, it's going to block their alpha 1 receptors and therefore blood vessels vasodilate. This was used as the cheap Viagra. It's non-selective, so the side effect was, yes, profound vasodilation, which helped with the erection, but also can lead to low blood pressure. And in patients who overdose on phentolamine, there can be a reflex arc that I'm going to teach you about in Unit 3, which leads to an elevated heart rate. And that can be very dangerous for people who have underlying heart conditions. So phentolamine can be used if someone was given too much, as I showed here, previous slide. If someone is given too much dopamine and it leads to, if someone has too much dopamine and to help elevate their blood pressure and they get hypertension, like too much blood pressure, we can give them phentolamine, which blocks the alpha 1 receptors, and therefore the dopamine can't bind to them, and that will help lower blood pressure. Other blockers, propanolol, careful, propanolol sounds a lot like isoproterenol. Isoproterenol stimulates beta 1 and beta 2 receptors. Propanolol blocks beta 1 and beta 2 receptors. This is great for the patient who has hypertension, and this drug can block the beta 1 receptors on the heart and leads to lower heart rate and inotropy, force of contraction. But this can be contraindicated in the patient with asthma because it will also block their beta 2 receptors, and that means loss of bronchial dilation. Again, we will talk more about these drugs in class. I'm going to make sure you understand what I want you to know for testing purposes. That concludes our review of the drugs that affect the autonomic nervous system. And this is just a short list. You'll have so many more that you will learn in PhRME. Thank you.